Good evening, everyone. Thank you for joining us this evening for our PA Health Talk program. This evening, we're pleased to bring you a presentation on genetics and risk for developing breast cancer. Just as a reminder, we received a lot of questions during the registration time, and we have those. We'll be sure to address them at the end of the presentation. If you have a question that comes up during the program, we welcome you to put it into the Q&A at the top of your screen, and we'll try to get to as many as we can before the end of the program. At this time, I'd like to introduce to you our speakers for the evening. We have with us two of our genetic counselors. We have Rachel Schwiter and we have Gabrielle Shermanski. And then we also are joined by our breast program nurse coordinator, Rebecca Vandervecken. So with that, I will stop talking, and Rachel and Gabby, I'm going to have you kick off the program for us. Thank you.
Thanks so much. It's so nice to be here with everyone. Thank you for taking a little bit of time on your Wednesday evening to chat with us about genetics, breast cancer, and our high-risk breast clinic here at Geisinger. Next slide. So Rachel and I would like to chat with everyone just a little bit about genetics and genetic counseling and when to refer to a genetic counselor here in cancer genetics. And we'd like to tell you a little bit about in general, our cancer genetics clinic here at Geisinger. As you can see on the screen, there's a few different cancer type blurbs here, but we do typically, look for certain things in genetics that might make us more suspicious that there could be potentially a hereditary cancer syndrome going on in a family. I'm going to start with the top left box, but that focuses mostly on breast cancer. So some things we look for in families or in a patient themselves are any breast cancer diagnosis at age 50 or below, if there's at least 3 family members or more diagnosed with breast cancer, triple negative subtype, that's just a more rarer specific type of breast cancer that we can see, and if there's a male relative in particular diagnosed with breast cancer. Moving down to the bottom left with pancreatic cancer, really if there's any pancreas cancer diagnosed at any age, if there's a first degree relative with pancreatic cancer, and specific types we look for as well. The top right for ovarian cancer, again, any age of diagnosis and a first or second degree close blood relative with an ovarian cancer diagnosis, regardless of the age of onset. And then prostate cancer, if it's high grade or an advanced stage or typically metastatic, confirmed, or if there's at least 3 family members with prostate cancer in a family. In the middle box, there's a few other things we look for hereditary cancer risk assessments. Some patients, when they're diagnosed with cancer, they undergo somatic tumor testing, or basically genetic testing is performed on the tumor itself. So in those cases, we look for specific genes, 2 of them being BRCA1 and BRCA2, which might pop up as a red flag, or if the patient's unaffected, if their family member underwent this type of genetic testing upon their cancer diagnosis. So we do look to see if relatives have some type of positive result, or we also refer to that as a mutation in not only the BRCA genes, but many others that we'll dive into next. Next slide, please. Moving on to our breast cancer risks by gene, Rachel and I wanted to list these out just to give a little bit more of a background for everybody. But you can see the BRCA1 and BRCA2 genes have the highest risk that we know of for developing breast cancer. But there are a lot of others listed here on the slide that are not so far behind those 2. They consist of the ATM gene, a gene called PALB2, STK11, TP53, and CHEK2. So they are associated with other hereditary cancer syndromes, ATM and PALB2 related cancer risk. STK11 is associated with a condition called Peutz-Jeghers syndrome, TP53 with Li-Fraumeni syndrome, and then CHEK2 related cancer risk. But the purpose of this slide is not so much to memorize percentages, but more so just to show you all that there are a lot of other hereditary breast cancer associated genes out there, not just BRCA1 and 2, although BRCA1 and 2 are the most popular and well-known established genes out there. Next slide, please. And then to access cancer genetic counseling and our services here, we do have a very, comprehensive team. There's about 7 of us that see patients in the clinic for cancer genetic services. We're currently seeing patients through telemedicine visits, so typically either by phone or by video consults. Sample collection is also pretty simple. It's typically just a blood or saliva or a swab sample, and those can be done at any Geisinger lab or at home. So we do offer both of those options for sample collection methods. Our next available appointment that we're currently scheduling out to is in December for routine visits, but we do offer lots of return, slots. So for example, if a patient had genetic testing and counseling years ago, we do offer return slots to kind of update them on any cancer screening recommendations in management, make sure they're up to date on all of those screenings. And we do, of course, offer urgent slots if, diagnosis, treatment, or surgical decision making, for example, in this case, if those decisions are pending treatment. So we do have quite the availability to offer services to anyone who's interested. And with that, I'm going to turn it over to Rachel for some updates on our MyCode genomic screening and counseling program.
Thank you, Gabby. And I wanted to take this opportunity to address the differences between genetic testing through a clinic appointment versus Geisinger's research program, MyCode. So during a cancer genetics clinic appointment, as Gabby said, they're mainly by phone and video these days. But what we do is walk through somebody's personal and or family history of cancer and check to see what is the likelihood of there being some sort of hereditary predisposition to cancers in the family. So if genetic testing is something that someone is interested in, we would walk through what that genetic test would tell us. If we do find a genetic risk factor, it does not mean that cancer is going to happen. It does not mean that cancer is present in somebody this day, but it does mean that they were born with a higher chance to develop various cancers. Oftentimes those breast cancer genes do carry risk for other cancers, which is why we have different flags based on family history, based on different types of cancers. So the testing that Gabby has referred to tests for all of the genes listed on the chart. The BRCA 1 and 2 genes are the most common genetic cause of breast cancer, but there are other more medium risk genes that we know of. Thinking about the MyCode program is really a broad research umbrella. So with that research umbrella, there are hundreds of studies going on behind the scenes. Some of them are looking at drug discovery. Some of them are trying to discover new genes linked to disease that we previously haven't seen or heard of. Another part of that MyCode program is the genetic testing portion. So through the MyCode genomic screening and counseling program, we screen everybody in the MyCode program who has submitted a sample, a blood sample. And if we happen to come across a risk factor for the BRCA1 or BRCA2 genes, we will contact that person and let them know, hey, as part of your participation in the MyCode program, there is this genetic risk factor that we found that could impact your health. And with the MyCode program, sometimes we catch people off guard. Sometimes people maybe submitted a sample years ago and we're kind of going through and just now returning results to patients who have submitted their sample years ago. So the MyCode program is not a substitute for genetic testing that is offered through the clinic, mainly because the genes that are tested for through the MyCode program are a very small subset of what we can test for in regards to other breast cancer genes. So That's an important distinction that I just wanted to share, the differences between Geisinger's MyCode program and clinical testing. On the next slide, there's just a list of multiple studies that are going on behind the scenes with MyCode data. So as you can see, there's studies on kidney disease, and there are studies looking at hereditary risk factors to cancer. So these are all good things happening in the background that, you know, we of course couldn't do without hundreds of thousands of people that have been willing to contribute their sample. So with that, we do have additional information on the next slide about how to contact us. So if you are thinking about your own family history and thinking, hey, I have somebody in my family who had breast cancer at age 40, that is a red flag to start thinking about hereditary risk factors. If there is somebody who had ovarian cancer in the family, that's another flag that we consider genetic testing. So this is our phone number to reach out to our clinic and learn more and to help get an appointment with us. And I will pass things over to Rebecca.
Great, thank you so much. So I'm here because I'm going to speak briefly about our high-risk breast clinic. That is the main reason behind tonight's presentation. So at Geisinger, throughout Geisinger's system, I'm based out of the Northeast, but at all of our sites, we do offer a high-risk breast clinic. So what does that mean, and even how do we get here? So many people worry that they have an increased risk for breast cancer, or maybe they think I have a relative, but am I normal risk? Am I high risk? So the very first step is a formal risk assessment. And this is completely free of charge. So your first step is either myself or my counterpart in the central region or the Scranton region sends a thorough intake to you, and you send back all of your information. And we put this in the software program that we have. So the software program actually generates out your risk using several different models. So it's a pretty broad program that we utilize. And this tells us, are you high risk or are you normal risk? There are many times where we get to this point and we learn a patient is normal risk, and we can let you know, you can have some peace of mind, you can have a sigh of relief, your risk is not elevated. If you still want to be evaluated, we are happy to see you. Or maybe you just want that peace of mind knowing my risk is normal and I'm okay and I can follow with my family doctor. If your risk is high because of family history or genetic testing or personal factors, we do work closely with our genetics team as well as our radiology team. So we have our surgeons and our mid-level providers that see you for breast exams, making sure nothing's abnormal. We work with our genetic counselors to make sure that we're testing you appropriately and keeping up to date on any testing. And we also work with our radiology team. Many women question about having additional imaging. Is a mammogram enough? Do I need an ultrasound? Do I need an MRI? So we do work with our radiologists as well, making sure that if you are of higher risk, we're adding in those extra testing so we keep a closer eye on you. And how can you get here if you're interested? You can ask your family doctor, your OB, any provider for a referral to the high-risk clinic. That kind of puts you on our radar, and we reach out and begin that intake and triage process. The Geisinger website, there is also an option to even self-refer. You can put in your information and you will be contacted to do that intake assessment as well. And that is all I have on the high-risk clinic, so thank you.
Thank you, everybody. So that concludes the formal part of our program. Forgive me, I'm going to come back on camera. Our formal program, we did receive, as I said, a number of questions that came in prior to tonight. So I'm going to go through those one by one. Apologies, Rebecca, Gabby, Rachel, if some of them are a little bit maybe of an overlap of what was discussed, but here we go. We'll kick it off. So the first question that had come in was, what is the cost for genetic testing and does insurance cover it?
I can go ahead and start off with that one. So that's a very good question. That's probably one of the most common and popular questions that we receive for any genetics consult with pre-test counseling. So the bottom line is, it's hard to say. So every insurance is different. It really is insurance dependent. It often depends on the time of the year as well that a patient is coming to see us, because it truly to, in some cases, has the patient met their deductible? Do they have a co-insurance? What does their benefits package look like? What does it outline in particular? So that is one of the major topics we do cover within our genetic counseling visits, since it is so patient and insurance dependent. So most certainly that's something that if anyone has questions about, which I'm sure most of you are thinking about that in terms of cost, we can definitely address that during appointments. What I will say though, and comment on, is that genetic testing in general has become far cheaper than it has been within the last 10 to 15 years. So I'm sure, and it still is, the stereotype out there that genetic tests hundreds to thousands of dollars, whereas depend on insurance. There's a lot of labs that we use today that do have self-pay options or patient assistant programs. So they do work with patients, but from a financial perspective to reduce the costs if needed. So that is the bottom line when it comes to insurance coverage. I'm not sure if you have anything else to add, Rachel.
Just to add really quickly that one of the labs that we work with commonly to run the genetic testing has shared with us that most people, if they do have an out-of-pocket cost, it is about $100 or less. So like Gabby said, a lot of people, they're concerned that the genetic testing is $1,000, and very, very rarely is that the case anymore.
Okay, thank you. Next question. Does the MTHFR variant predispose one to breast or any other cancer?
I can start us off here. So thank you for submitting the question. And the MTHFR gene is something that is also pretty common. So the MTHFR gene does not have any significant links to breast cancer. There have been a lot of research studies on this gene. What we do know about the MTHFR gene is that in people who inherit one non-working copy from each parent, so they have two non-working copies of the gene, that can predispose someone to clotting issues, but there is no association with higher risk for breast cancer.
Okay, thank you. I'm just going through just to make sure I try not to ask any duplicate questions. So next one, how often should I get genetic testing redone? Screening for daughter despite no current genetic markers. Let me think. So it looks like it's saying maybe she's having her daughter screened despite no genetic markers. And then the question comes in is how often should you get testing redone, if you should get it redone?
That's a great question. So in general, and it depends on when the testing was done, but if it was done probably within the last 5-ish years or so, typically the genetic testing the genetic testing technology is the most up-to-date that we have. So with that being said, typically if a larger panel of genes is being ordered, because there are so many hereditary cancer risk factors out there, and naturally within genetics and genetic testing today, we're ordering pretty large panels for patients. The standard is not only, for example, BRCA1 and BRCA2 today. Of course, depending on some insurances, that might be the case to start for coverage purposes, but the standard is typically these days to order pretty large panels. So the bottom line is if genetic testing was done more recently, usually it's a one and done process if a bigger panel was ordered. The only cases where we would think genetic testing might need to be not necessarily redone, but just adding on more genes, or maybe, redoing the BRCA1 and BRCA2 gene because technology has changed, probably within some of those cases where testing was ordered 10 to 15 years ago at this point. So if you or a loved one, know that you have had genetic testing, or your relatives have, your friends have, and it was quite some time ago, we definitely encourage you to come back in to have the conversation, especially so the cancer genetic counselors can look at the labs that have performed the testing, check the technology, check what genes were ordered, how many. That way, if updated genetic testing is indicated, we can properly order that for you at a respectable lab.
Thanks, Gabby. The next question: does family history of breast cancer in your 80s put you at higher risk? Mammograms are recommended at 40, but I know several close friends and peers who have developed breast cancer in their 20s and 30s. Should we be screening for it earlier?
That's a great question. I'm happy to answer both portions of that. So the first thing, as far as relative breast cancer in their 80s, it would really probably depend on how close those relatives are, as well as how many. We look more, postmenopausal breast cancer is not as much as a red flag as premenopausal, but still, if it is multiple aunts and a mother and a grandmother, then that's a different discussion. When it comes down to the screening, this is kind of where that supplemental screening comes into the conversation. 20% seems to be the mark where national guidelines kind of flip, and that's where we can begin using screening MRIs as well as screening ultrasounds beginning at age 25. So for patients in our high-risk clinic that are in their late 20s, their 30s, they are getting screening MRIs, they are getting screening ultrasounds. The reason we don't begin mammograms sooner is because in young women, our breast tissue is very dense. And if you have ever seen a mammogram picture, dense tissue would kind of be like a blizzard, and you're trying to find a polar bear. So really, that is the reason why in our younger women, we try to stick with our ultrasounds and MRIs, which through the high-risk clinic, that is offered yearly every 6 months. So it's an important fact, if you are concerned about that risk, to be followed so you can get those additional screening options.
Thanks, Rebecca. Next question. I have tested positive for the BRCA gene. Can we go over this a little bit more?
I'm happy to start with this question here. So first off, thank you for sharing that you did the genetic testing and you did test positive. And I'll start by saying that it's not always the easiest news to hear. Of course, people go into genetic testing, ideally hoping to find out a little bit more about their risks and have some anticipation of what the results might be. However, you're not always prepared to hear that exact result when it applies to you. So it is a significant risk factor for developing breast cancer as well as ovarian cancer. Now, there are subtle differences between the BRCA1, BRCA1 gene and the BRCA2 gene, but generally the screening recommendations for BRCA1 versus BRCA2 are the same. So to address that higher level of risk, as Rebecca mentioned, we do initiate supplemental screenings, and we initiate those screenings at an earlier age than average. So for example, if someone is at average risk, they would get mammograms starting at age 40, typically. For BRCA1 or BRCA2 genetic risk carriers, we want to start screening at age 25, and that does start with breast MRIs, and then we eventually phase in mammograms around age 30. So the idea is earlier screening, more frequent screening. On the opposite end, we do consider risk-reducing procedures. So some people with genetic risk, they opt to go through with regular imaging screenings. On the other hand, some people who have very strong family histories might feel that they want to take a more significant step and do preventative surgeries. So we work very closely with Rebecca and our breast surgeons to help our patients with genetic risk better understand their options, and we do not jump into a surgery decision. You know, these are conversations that are had over multiple time points with multiple different people, just to make sure that, you know, someone is ready, and we make sure that they speak with specialists. So I hope that answers the question a little bit more.
Great answer, Rachel. Thank you. Okay, the next question that comes in is, if a grandmother or a mother didn't have genetic testing, how do you proceed with evaluating your own risk?
I'm happy to answer that. So when we do our high risk intake, we look at family history as well as personal history. So when it comes to family history, as Gabby and Rachel spoke earlier in the evening, a lot of these genes are tied not only to breast cancer. So sometimes we see a patient who has no family history of breast cancer, but has a family history of ovarian cancer or pancreatic cancer. So any cancer is still a risk factor. And we then also look at your personal factors. So even in a person with maybe no history of cancer, there are a lot of personal factors. So for example, we look at history of hormone replacement, age of your first period, menopausal status, number of pregnancies, number of children, how old you were when you had your first child, if you have children, previous fertility treatments, breast density, weight, alcohol, smoking. So there are a lot of personal risk factors that go into that assessment as well to calculate the risk.
Thanks, Rebecca. A few more here. This one's a personal question here. I just found out a cousin that I found on Ancestry DNA is the third generation to have the BRCA2 gene from my grandfather's sister. My father's sister, my half-sister, and I all have never given birth, but discovered we all had early hysterectomies. That's kind of a statement, but I'm guessing is sort of asking the question of, you know, not having given birth, early hysterectomy, but now finding out that they're testing positive for the BRCA2 gene. Is there any comments on that one?
Yeah, I can start with that one. And that's a great question, because we do often see a lot of patients or their family members who've, you know, reportedly pursued genetic testing, and they've had testing through Ancestry or 23andMe, or maybe other direct-to-consumer companies out there. So I think that's very important. First of all, knowledge is power. We know that those companies are great for certain things, but really, if there is any type of result that, you know, comes up with one of those companies that isn't typically one of the labs that we would order for clinical genetic testing in practice, you know, we do recommend that those patients come in to see us for confirmatory testing. However, if that is not an option, depending on the relative who had the testing already or that specific affected relative for various reasons, you know, for this specific individual, you know, I would recommend coming in just to talk it through a bit, and then maybe order some confirmatory testing just to be sure that, you know, it is truly a positive result for you in particular, because we don't want there to be any type of false positive or, you know, result that isn't truly as accurate as it should be, especially when using one of those companies. So not to say, you know, that they are totally inaccurate with all of their results, but when it comes to learning about, you know, medically actionable conditions in that respect, we definitely recommend to come in and see us, get some follow-up, have the confirmatory testing, and then go from there if the result is truly positive. But what is good here that I'm seeing is that a lot of the women that were mentioned in that statement, did get early hysterectomies. So that does reduce the risk of ovarian cancer completely. But what we do know especially with the BRCA2 gene, as Rachel went over, and I went over the differences between the BRCA genes versus other hereditary breast genes. The BRCA2 gene has a lot of overlap with other cancer types. So breast and ovarian are two of them, but we can also see risks for pancreatic, prostate in males, and a little bit of melanoma, skin cancer as well. So with that being said, great to hear about the early hysterectomies for the woman in the family, but there are other cancer risks that we may need to address if being seen.
Thank you, Gabby. This is sort of like a two-part question. So the first part says, is having dense breast tissue hereditary, and is this a factor related to any of the genetic markers for breast cancer? And then the second part of the question is, do the different genes indicate a type of breast cancer you may have a higher risk for? So let me know if you want me to answer them separately or if you're okay to answer them together there.
I think they are going to have to be separate. I can certainly speak to the first portion as far as the density and the risk and genetics tied to density.
So we'll have you answer that, and then sorry, I just totally cut you off, Rebecca. We'll have you answer that, and then I'll re-ask that second part just so it's nice and fresh.
So breast density is really independent of genetics, family history. It's really based on you and multiple factors based on your hormone levels. As women get older, we go through menopause, estrogen levels drop, and unfortunately, fat levels often increase. Doesn't mean you're going to gain weight, but it does change the composition of your breast tissue. Also being on hormonal birth control, hormone replacement, fertility treatments, even certain non-hormonal medications can affect breast tissue as well. Your body composition, if you are losing weight or if you are gaining weight. So many factors affect the way that your breast tissue is, and it changes throughout your lifetime as well. So dense tissue is considered a risk factor. It is very common, but it is considered a risk factor because on imaging, like I said, dense tissue is white, but anything abnormal is also going to be white. So if you're extremely dense, that's where we use that analogy of trying to find a polar bear in a blizzard. So oftentimes in women with dense tissue, when they get their mammogram, our radiologist will often reach out to us in the high-risk clinic to discuss supplemental MRI, supplemental screening, other screening modalities in addition to the mammograms. So I hope that kind of covers the risk tied to density. It makes imaging more challenging, but that's why we discuss supplemental imaging. And it's not really tied to your family history so much as it's tied to you. But Gabby and Rachel can certainly speak to the second part, more so about the genetics.
Gabby, Rachel, would you like me to re-ask that second part?
Yes, please.
Okay, so the second part of that question, or just a separate question, do the different genes indicate a type of breast cancer you may have a higher risk for?
Yes, so we do know that various genes carry not only different risk levels for breast cancer, but some genes can be linked to different types of breast cancer. Overall, these different types of breast cancers are screened for in the same way. For example, the BRCA1 gene, we know that is linked to the triple negative type of breast cancers, more so than the hormone positive breast cancers. As Gabby had mentioned, the triple negative breast cancers, they're a little bit more rare, a little bit more aggressive. So those BRCA1 carriers, we know that, we are watching out for a more aggressive type of breast cancer compared to other genes. One of the other umbrellas of breast cancer types is the more common ductal type of breast cancer, where the cancer is in the milk ducts, versus a lobular breast cancer. So different genes confer different risk for lobular breast cancer. Again, they are screened the same way. Gabby, I'm not sure if there's anything else you would add.
No, I think that sums it up pretty nicely.
Okay, thank you both. We have one last question that was pre-submitted. Currently, there are no questions in the Q&A. So at this point in time, this will be our last one. The question is, if not so immediate relatives had breast cancer, is the chance lower than an immediate relative?
Happy to speak to that one. So certainly we look at first degree relatives the most. Having a parent with cancer, a sibling, they are going to increase your personal risk more than any relative. However, we do also look for trends on one side of the family. So maybe mom didn't have cancer, but an aunt and a cousin, did. So we look more so at trends all on mom's side or all on dad's side. If it comes down to, oh, I only have a second cousin with cancer, then your risk, is certainly average, if not low. But having only a distant relative rather than a first degree certainly does lower your risk. But if it's a lot of further degree relatives on one side of the family, that still might be a trend. I don't know, Gabby or Rachel, if you want to add to that as well.
I think, thanks, Rebecca. I'm just going to kind of echo your comments there. I mean, we kind of follow the same methodology within cancer genetics. So even, we look mainly at what we term as close blood relatives, and current guidelines that we use categorize those as first, second, and third degree. So parents, siblings, children, aunts, uncles, grandparents, and cousins on both the maternal and paternal side in particular. So we do, take into account first, second, and third degree blood relatives. But of course, if there are distant family members with, breast cancer or any other cancer types, we're still adding those onto our pedigrees, or also known as our family trees. And, we're always evaluating even more distant relatives as part of the hereditary cancer risk assessment in general.
Okay, well, there are no new questions that have come in. We went through all the questions that were pre-submitted. So at this point, I would like to say thank you, Rebecca, Rachel, Gabby. Thanks for sharing your time with us this evening. Thanks for sharing this information with us. Everyone who's on the call, you'll see on the slide where we have an email address and a phone number on the screen, and those go directly to the genetics team at Geisinger. So if you have any questions or would like some more information, maybe wonder about next steps, we welcome you to utilize that email or give them a call, and they'd be happy to discuss with you next steps or just give you some more information. So with that, we'll close the program out, and thank you all so much for joining. Have a great night.